Thank you very much for the opportunity. It is my privilege to be moderating and chairing this session where we have two speakers, Dr. Lalit Chimpi and Dr. Venkat Iyer, who have been introduced to you before. As an introduction, all that I would like to say is that postprandial distress syndrome and dyspepsia are so very prevalent that it actually affects very significantly the quality of life of the patients who are affected by this. Now, commonly referred to as dyspepsia, dyspepsia seems to be a big basket into which you can put many diagnostic issues. But when we talk of dyspepsia, and as I understand, a lot of the audience today would be general practitioners, physicians. It is important for us to understand how we need to approach these patients with dyspepsia. And once you've approached them properly, of course, there has to be, we should also have a good understanding of the connection that it has with things like Helicobacter pylori and some of the very discrete entities like the postprandial distress syndrome. Some of them go on to postprandial pain syndrome. All these would be discussed this evening by our two very eminent speakers. The exact pathophysiology of postprandial distress syndrome is still not very clear, and there are so many theories behind it. Most important of it is, of course, the psychosocial component. And also, we now started talking about the gut-brain axis. So therefore, it is very crucial that we understand what this postprandial distress syndrome is all about, as it represents a very significant health concern and requires tailored approaches for effective symptom relief and improved quality of life for affected individuals. With this brief introduction, we'll slip into the main session today. And the first talk today, this evening, is going to be by Dr. Lalit Chimpi, who's been introduced to you before. And I gather that he is going to be talking to us on this problem of postprandial distress syndrome. Dr. Lalit Chimpi, over to you. After the two talks, we will have the Q&A session. So please keep those questions coming in. And it will be our effort to answer all questions that have been put to the panel. Over to you, Dr. Lalit.
At the outset, thank you, looking for organizing this meeting. And let's see, in the next 20 minutes or so, I'll just try to introduce the topic. And maybe after that, Dr. Iyer can take up more about the molecule, and then we can have Q&A. So I'll just share the presentation and share my slides. Is Saraswati visible?
Yes, sir, it's visible.
Okay. So as Dr. Ramesh introduced, and we'll be discussing a little more about postprandial distress syndrome, which is a fairly common symptom that a lot of our patients come to us in GI practice and OPD. And let's try to understand something about it and the diagnostic approach. So we all know that dyspepsia is very common. It's a very sometimes, as Dr. Ramesh mentioned, is very difficult to define in terms of symptoms. Because there's a myriad of different symptoms that the patients come to us when they say they have dyspepsia. And if we see population studies, at least 20 to 30%, of our patients in whom we see in OPD make up for patients who are having dyspepsia. Now, on diagnostic workup, about 20 to 30% of patients with dyspepsia are found to have diseases that account for the symptoms, and those wouldn't be classified strictly as functional bowel diseases, but they have organic dyspepsia. Say maybe someone has, gastric cancer, someone has severe diabetic gastroparesis, someone has other upper GI problems which are giving rise to dyspeptic symptoms. So these are things that we will not discuss today. But the majority of those in whom we see in our OPD will have functional dyspepsia. So about 70 to 80% of would have functional dyspepsia, about 20 to 30%. And while the precise prevalence in India is not available, we have a lot of studies where around 7% to 40%. In India, physicians and 20 to 40% of patients with functional criteria disease. So if we look at organic causes, patients may come to us who have gastric or esophageal cancer and they have dyspeptic symptoms. Sometimes you have gallstones which produce these kind of symptoms. Patients with chronic pancreatitis or malignancies in the abdomen can present with dyspepsia. And there are certain kind of alarm symptoms that we look in these patients, and I'll discuss a bit on that a little later. You also have patients who have lactose intolerance who may not just come to you with diarrhea, but also with dyspeptic symptoms. And other causes like infections like GRDSS, for example, may also come to you with functional dyspepsia. But in patients in whom you really don't find any structural or biochemical explanation for the symptoms, those are the ones who are classified as functional dyspepsia. Now, we all know that dyspeptic patients come to us with varying symptoms, and the most common of them are postprandial fullness, especially in the epigastrium or the upper abdomen. They may come to you with epigastric discomfort or pain, early satiety, bloating is a common symptom, belching is a common symptom. People might come with nausea, vomiting, and weight loss because of reduced intake. So these are the symptoms that we generally encounter. Now, if we see the Rome 4 criteria, we need to have some kind of objectivity when we're describing or defining people with functional dyspepsia. So the presence of one or more of the following symptoms thought to originate in the gastroduodenal region. So patients should have one of these symptoms. The first is bothersome postprandial fullness, bothersome early satiety, bothersome epigastric pain, and bothersome epigastric burning. And of course, you need to have no evidence of structural disease to explain the symptoms. Symptoms should be present during the last 3 months at least, with the onset of at least 6 months before diagnosis. So, like we have Rome 4 criteria for many other GI diseases, we also have Rome 4 criteria for functional dyspepsia. Now, there are two major broad categories when you say patients have functional dyspepsia. So on one side, you have postprandial dyspeptic symptoms, or known as PDS, and then you have the epigastric pain syndrome. So if we see functional dyspeptic patients, they may have an overlap of both of these symptoms. So someone might come to you with bloating, satiety, nausea, retching, vomiting, loss of appetite. And then you have the other subgroup who comes to you with upper abdomen pain and cramps, and those go more in epigastric pain syndrome. And these are patients in whom you need to differentiate them between having a functional dyspepsia and say, for example, organic diseases like peptic ulcer. There are various lifestyle factors, there are different dietary factors, there are psychological factors, psychosomatic factors, which may be responsible for the patient's symptoms. So you have organic, one would say at a microscopic level, or at a motility level. When you have gastric dysmotility, you have delayed gastric emptying, disturbed intragastric distribution of food, reduced accommodation, and I'll come to that a little bit. And then you have meal-related factors, like, for example, meal size, someone who's cooking a very heavy meal, the dietary composition. So if you have an excessively fatty meal, specific foods like acidic fatty foods or very spicy foods, high carbohydrate containing foods, high fiber foods, these can cause dyspepsia. Psychosomatic factors also play a very important role. So stress, anxiety, other issues like smoking, coffee, alcohol, presence of obesity, these also contribute to patients having dyspeptic symptoms. And like a lot of functional diseases, you have people who have visceral hypersensitivity. So they might not really have a gastric distension, but because of the hypersensitivity of the gastric or the duodenal wall or the nerves, you might have patients perceiving more uncomfortable feelings than they actually have in their dyspepsia is not only, as we all know, there's a very good brain-gut axis communication, which is two-way communication, and a lot of these symptoms can be modulated by what is going on in the brain. So anxiety and stress can increase dyspeptic symptoms, as I said, visceral hypersensitivity. And in addition, if you have inflammation either in the stomach or the duodenum or the esophagus, then this inflammation itself may precipitate or may increase your symptoms of dyspepsia. So these are the major kind of pathophysiological mechanisms. As far as the functional aspect of it is concerned, there are 3 or 4 factors which really are responsible for dyspeptic symptoms in a lot of people. So, persons may have reduced fundic accommodation, abnormal distribution of gastric contents, delayed emptying, abnormal myoelectrical activity, and dysmotility in the bowel. So, these are kind of, one would say, functional aspects of pathophysiology which can cause dyspeptic patients. So, if we see the percentage of patients in whom these pathologies or these pathophysiological mechanisms play a role, you can have impaired accommodation in the gastric fundus in about a third of patients, delayed gastric emptying, and hypersensitivity to gastric distension. So about a third of patients have all of these together. The most important is the abnormal fundic relaxation in response to meal. So normally when you have a meal, the fundus of the stomach will distend and will try to accommodate the extra food that has come because of neural mechanisms and local neural reflexes. And then you have a receptive relaxation of the fundus. So if that doesn't happen, then you get impaired fundic accommodation, and then you get a redistribution of the food to the enteron. And this, a lot of patients may have this reason why they develop dyspeptic symptoms. So how do you approach patients with functional dyspepsia, and how do you treat them? And so treating functional dyspepsia a lot of times is difficult because patients may not have objective symptoms which can tell you that, okay, you have a 40%, 50% or 80% improvement in symptoms, because there is no pathological test that you are doing to really objectify how much a response there is. There is no definitive cause. There are multiple pathophysiological factors. There's an element of psychosocial factors. There may be an overlap with reflux, gastroesophageal reflux, an overlap with irritable bowel syndrome, especially in patients who have a lot of psychosomatic issues. You have an overlap with H. pylori infections, or these are structural issues which can cause an overlap. So treatment may be difficult in these patients. And then you have effective therapies, but sometimes there's a little limitation on that. And our main focus actually on treating is to treat the symptom rather than the disease, because it's more of a functional issue, and similar to other functional issues like, or problems like irritable bowel, for example, where you really need to treat the symptom or predominant symptom that the patient has. So what do you do in an algorithm when you get patients coming to you with dyspepsia? So history taking is the most important fact that we need to remember in a good clinical examination. You need to rule out systemic diseases like cardiac diseases. For example, a month back I had a patient who came with a lot of dyspepsia, uneasiness, and then later on found out to have dilated cardiomyopathy, a congested hepatomegaly, and that was causing his dyspeptic symptoms. So examining other systems is as important. Hypothyroidism a lot of times can come to you just with dyspepsia and just a feeling of being ill, of not being well, of having fatigue, just some mild edema. Dyspepsia is a fairly common diagnostic symptom in which patients who are first time diagnosed with hypothyroidism can come to you. You then have other issues like bacterial overgrowth, or SIBO as we call it, patients with giardiasis, and these may come to dyspeptic patients. It's also important to ask medication and drug history, patients on an antihypertensive, lipid-lowering agents, antibiotics for other reasons, and these may be also responsible for their dyspepsia. One needs to rule out organic disease by doing liver function tests, getting an ultrasound done, make sure that there are no organic causes over there. If there are postprandial symptoms, you need to also ask if the patient is diabetic. He has neuropathic complications in addition to his diabetes, because those are patients in whom dyspepsia seems to be more common. And then you have rare connective tissue disorders, which can also present as dyspepsia. So good history and good clinical examination is essential. Patients may have some alarm symptoms, like, for example, an elderly patient coming to you with acute dyspepsia needs to be worked up. Someone who's having weight loss, recurrent vomiting, you need to rule out an organic cause. Patients coming with dysphagia, whether they have a stick pharyngitis or a malignancy. If there's any evidence of bleeding, a history of hematemesis or melena, definitely you should not leave these patients alone and investigate to see if they have any organic cause. So hematemesis, if there's a family history of cancer, and as I said, new onset dyspepsia in patients who are elderly, definitely something which you should investigate. So there are different tests where you can assess gastric functions and symptoms. And when we see the algorithm, these tests don't immediately come to our fore when we are investigating. A lot of times we do give empirical therapy, implying that most patients, since they have an absence of organic disease, that is something we've ruled out. Most of the times we give prokinetics to our patients, they do well. And in which case you really don't need to go after any of these tests. But patients who are coming with recurrent symptoms or symptoms which are not getting better with their medications, these are patients in whom these tests may be required. So I'll just come to that in a moment. So how do you approach such patients with symptoms suggestive of dyspepsia? You do a physical examination, see if there are any alarm features. If there are no alarm features, you consider empirical therapy, see if the patient's symptom resolve. If they resolve, yes, then you can ask them to come and treat them as needed on an as needed basis on follow-up. If their symptoms are not resolved, you can consider testing and treating H. pylori, either by a breath test, stool test, or an endoscopy if you've done that for ruling out organic disease. If there are alarm features, do an endoscopy. If any abnormality is identified, then you treat them accordingly. If then they go into the realm of secondary dyspepsia. If they are not having any abnormality organically, you've tested H. pylori, if it's positive, you treat it. If the symptoms resolve, again, you need to just follow them up. And if the symptoms don't resolve, then maybe you can come to these other diagnostic tests which I have covered. So this is essentially the same kind of algorithm that we have found. So rule out secondary dyspepsia, rule out H. pylori associated dyspepsia, and if both of these are not there, then you manage them as functional dyspeptic patients and then take it on from there. Depending on what symptoms the patient has, whether the patient has postprandial distress or patient have an epigastric pain. So there is an overlap between them, but if you see which is the one which is predominating, you can treat your patients accordingly. For example, if someone has postprandial distress syndrome, then the first agent could probably be a prokinetic rather than a proton pump inhibitor. And then if they don't respond, you can add up a proton pump inhibitors or neuromodulators as second or third line. On the other hand, if you have someone who's come to you with epigastric pain syndrome, then the first line should be proton pump inhibitors, and the second line, if patient doesn't respond, can be a prokinetic agent. If our patients have not responded to prokinetics or they have recurrence after the prokinetics have stopped, then you need to also consider adding them on drugs which act on visceral hypersensitivity. For example, you can try tricyclics in that case, along with your proton pump inhibitor and your prokinetic. If there is no adequate relief, then you might go to functional testing, experimental therapies or experimental testings, and try to find out what exactly is wrong where is the patient fitting in, whether I need to change medications, put him on antidepressant combinations or other maybe an antiemetic, or then if nothing is really coming by, then whether the patient has a severe gastroparetic illness, say for example having diabetes. So these are the ones which can come a little later on. I'll hand it over back to you, Dr. Ramesh.